You're listening to Medscape's In Discussion series on multiple myeloma, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Joseph Mikhael, Chief Medical Officer of the International Myeloma Foundation and Professor at TGen City of Hope Cancer Center. Relevant disclosures can be found with the episode show notes on medscape.com. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, my name is Dr. Joseph Mikhael, and welcome to Medscape In Discussion Multiple Myeloma. Today, we're talking about triple-class refractory multiple myeloma. I think this is actually a particularly important topic because for many years, we have had three major classes of agents in myeloma: proteasome inhibitors, immunomodulatory drugs, and CD38 monoclonal antibodies. And despite the great advances of those three different classes, unfortunately, patients will ultimately become refractory to all three. So what do you do in that context? What new treatments do we have available, or do we just have to recirculate what we've used before? So that's really the focus of our discussion today. And as always, it's a privilege and an honor to share the microphone with not only a world expert in the field of multiple myeloma, but a very dear friend, Dr. Saad Usmani, who is the chief of the myeloma service at Memorial Sloan Kettering Cancer Center. Welcome, Saad.
Thank you so much, Joe. It's a pleasure to be here with you, and I'm looking forward to our conversations on this topic.
I'm looking forward to it as well, because I know that you have really been one of the pioneer leaders in a lot of the work that we're going to be discussing today and some of the novel approaches and therapies, including CAR T-cell therapy. So before we dive right into the topic, let me set the tone with a case. And this is the kind of case that I'm sure many of our listeners see on a regular basis. I saw two patients exactly like this week, frankly, or very similar to this week, where you have a patient who has gone through 4 different lines of therapy. They had their induction therapy. In this case, the patient did have an autologous stem cell transplant, was on maintenance therapy, and has had 3 further lines of therapy, combining monoclonal antibodies and immunomodulatory drugs or proteasome inhibitors. This patient, for example, at one point had daratumumab plus carfilzomib, at another point had elotuzumab plus pomalidomide. And so now the patient is truly triple class refractory. And they're sent to me, and in this case, sent to both of us to think about what do we do now? The doctor said to me, well, I know that there are new therapies. I know that selinexor is there. I know that belantamab's there. I've heard that CAR T is there. I'm not sure I can get it. But how do you decide between those three? And that really is going to be the heart of our discussion today, to sort of walk through those 3 therapies and get your impression as to how you approached it. When will you choose one over another? And then maybe some pragmatic points that we can share together about how we actually administer these drugs. So even in a more generic sense, when that patient's presented in front of you, what kind of algorithm do you use in your head, Saad, to say, I may go the selinexor path, I may go the belantamab mafodotin path, or I may go the CAR T path?
You rightly described a patient scenario that we get very commonly at tertiary referral centers, and even in our practices as patients are doing fine. I think the things that we all pay attention to is the pace with which that relapse is happening. If patients are very symptomatic, or they're presenting with high disease burdens, they might, if they have extramedullary disease or even circulating plasma cells, we might favor getting some sort of conventional chemotherapy going first before we think about those subsequent options. But as we're thinking about the next steps in treatment, I always look at what the patient profile is looking like, what kind of side effects they have, what kind of comorbidities they have, because that may help you decide on that best next best therapy. We know the safety profile of each of these drugs, selinexor combinations, GI side effects, fatigue, the need to be in the infusion center on a weekly basis to potentially get fluids and supportive care measures. Can our patient, handle that? Do they have the social support structure to undergo that? with belantamab mafodotin, if you're thinking about a BCMA specific treatment, the way that I think about this is my patient, again, able to handle something like CRS? Am I concerned that they might be at a higher chance of neurologic or neurotoxicity events, if I were to go to the CAR T cell therapy route for those patients? Do I have enough time? It's going to take me 3 months at the very least, even if I register them today, to get them that CAR T infusion. Do they have enough time during this time period to actually wait for CAR Ts? Do I need to intervene now? And then, obviously, in terms of belantamab mafodotin, the orchestration with an eye care professional, whether patients already have pre-existing eye issues, whether they've had corneal transplants or any corneal issues in the past, which would preclude them from getting that kind of treatment. It's a very complex decision-making tree, but it all goes from looking at your patient and patient-related factors, prior therapies, the pace of disease, and then seeing what profile fits best for which patient.
Oh, that's a fantastic answer, as I expected. That's great. And I think that kind of rubric is really important. That, first of all, I like the fact that we have choice, right? Being a myeloma doctor now for almost 25 years, I remember the days when, frankly, we didn't have much choice. So having choice is a good thing. I think one of the things, even to say from the very start, is these three therapies aren't necessarily exclusionary, meaning someone may get one and then be able to go to the other. And in fact, we'll come back a little bit later to your experience with taking someone from one BCMA therapy to another. But let's unpack the three of them a little bit, because I really liked how you described that, we don't have a cookie cutter solution for everybody. You have to take into multiple factors, and in particular, the potential toxicities of each. And I think it's amazing that we do have choices, we said, and these are all very good therapies. I think we tend to feel that CAR T likely has the greatest efficacy of the three, although access to it, as you noted, was a challenge. But if we think about selinexor for a couple of moments, this is a drug that's kind of gone through a bit of an evolution. I sometimes say there isn't a drug in myeloma that hasn't gone through an evolution. Almost every drug we use in myeloma, we use it a bit differently now than when it first came out. Bortezomib came out IV twice weekly. Carfilzomib was twice weekly, and both of those drugs we pretty much use weekly. And at least in my experience now, I almost exclusively use selinexor weekly, and often at a slightly lower dose at 80 milligrams, maybe 100 milligrams in some patients. And I've really found that to be a tidal shift in being able to use the drug either just with dexamethasone or in combination. But what do you pragmatically do? You intimated it a little bit already that you want to make sure probably for that first month that they come in every week to get fluids and so on. What do you tell patients in advance? What do you do in that sort of prophylactic setting to prevent some of those GI toxicities that you mentioned?
So I do prime the patients. I think describing the side effects and what to expect to the patients is extremely important. Making sure that they understand that they will require antiemetic therapy, therapy with medications like Zyprexa, olanzapine during that first cycle or two. Supportive care measures are going to be extremely important. So creating a calendar for them with exactly what they need to do during those first two cycles of treatments becomes important. I also have a discussion with them about the fact that we will know within the first 2 or 3 cycles if this is working or not. So, we're going to be keeping a close eye on the myeloma labs. And Joe, I prefer to combine the weekly lower dose selinexor and dexamethasone with a proteasome inhibitor if I can. And so, I found that data to be compelling. I am actually more impressed with the carfilzomib combination in that, later line treatment than with the bortezomib combination, because many of the patients are already coming in with bortezomib resistance, and yet, you find them responding to the carfilzomib combinations, and that's Christina Gasparetto actually, I think had shown that data a couple of years ago.
Yeah, no, I agree with you. I have a very, very similar strategy. I tell every patient, first month is the worst month. That's when we want to cover what sometimes what I do, so as I call it, head nausea and stomach nausea. Like there's the classic stomach nausea. Everybody needs a 5-HT3 antagonist, but that head nausea, that's sort of, my teenage daughter's on a weekend feeling, I don't want to get out of bed. I have that sort of, if I describe it in a word, I'd call it meh. My kids use that word a lot. And I found that the olanzapine really helps with that and reduces some of that anorexia, along with exactly what you've said. They're getting a check once a week. If they're missing more than 2 meals in a row, we want to hear from them. And I think we really can nurture people through it. And I'm with you. My carfilzomib is my favorite partner to Seli. There are times I may have used bortezomib when it was necessary, but I agree with that combination. And you're going to know, just like you said, often really within the first 2 cycles, if it's really working or not. Now let's move on for a minute to belantamab, because there's been obviously, this was kind of another title shift in the way we do things in myeloma. The very first BCMA directed therapy is an antibody drug conjugate. What's your strategy with belantamab? How do you kind of think about it, and how do you practically administer it?
Belantamab, honestly, it came into the market a little bit ahead of time of the ide-cel CAR T-cell therapy, but all of us are aware of what was going on, from a logistics standpoint on trying to get ide-cel as a commercial option for our patients. Many centers were just getting 1 slot or maybe 2 slots on a monthly basis. But, BCMA is a very, specific lucrative target in myeloma, more so than CD38. And so, picking that kind of an option for a patient would be, we know that it's going to work. Belantamab mafodotin would work in 1 out of 3 patients. That's how I think about this. And if you look at the safety profile outside of the ocular issues, it's really well tolerated. So, I would prime if I'm picking a patient, I would pick the right patient, right? So you want to make sure that the pace of disease isn't explosive, and you're not going to be putting, the ocular side effects on top of what everything else is going on, with that particular patient. But then, orchestrating from the get-go with an eye specialist and making sure that that piece is worked out. You have to have your preferred partners in the community that you can send patients to right away. So we were able to set all of that up from our clinical trial experience in DREAM2 and other DREAM studies. And we kind of capitalize on that. I think, doing that would be super important. And here too, you'd know within the first 2 cycles. So within 5 weeks, 5 to 6 weeks, if it's working. If it is working, whether patients are having any eye side effects or not. So based on that information, you might have a patient who's responding but having no symptoms. You can actually continue to give the drug the way that it's supposed to be given. For patients who are developing eye side effects, you can back off of the schedule. And, I've had experiences where if someone is responding and developing eye side effects, I've held therapy for up to 12 weeks without losing a response, and then allowing patients to actually get better from the eye side effects. And then you can give it less frequently in lower doses to continue, so that they continue to get that benefit. But then if they're not responding and they're having eye side effects, there's no reason to continue the drug.
No, I think that's brilliantly put. I think, like we said earlier, every drug goes through its evolution. I think we're going to probably have an evolution where we use this drug less frequently than the planned every 3 weeks. Maybe the first 2 doses be given every 3 weeks and then back off. And for clarity for our audience, under the REMS program that belantamab is in, every patient must see either an ophthalmologist or an optometrist and have a slit lamp exam and a visual acuity test before each dose. Because this drug has a risk of keratopathy, we think it's probably a function of the toxin that comes with the antibody, the drug conjugate, as it were, somehow leaches out into the cornea. With time, it'll dissipate, but in some people, it seems to accumulate quicker than others, and they cannot have more than grade 1 keratopathy. If they're grade 1, you can continue treating, but if they're grade 2 or higher, the drug has to be held until it's back down to a grade 1. And I think your experience, Saad, actually is what many of our colleagues have been sharing with us, that this drug works if patients do respond, and if they develop some keratopathy. Obviously, by definition of the REMS, we have to hold it, but it's amazing how many people seem to hold their response while we're holding the agent. And so again, in patient selection, one of the things I talk to my patients about is, how worrisome would some blurriness of vision be? And maybe that younger executive who's driving to work every day, for those of us who are still going to a physical place, it may be different than someone who is already being driven and may not have as much of an issue. Well, that brings us to our third and final topic, which is, I know, the one that you want to dive right into, which is CAR T-cell therapy. I mean, no disrespect to the molecules we've talked about already, but we've seen in very heavily relapsed setting that drugs like selinexor and belantamab can give us 25, 30, maybe, as you said, 1 in 3 response rate. We're literally tripling that with CAR T-cell therapy, both with ide-cel that was approved last year in 2021, and now just as recently in end of February 2022, we've seen the approval of cilta-cel. So maybe, Saad, you can just talk to us a little bit about that sort of response, and then a little bit on the toxicity. You already mentioned a little bit about CRS and neurotoxicity, and then after we can talk a bit more about access. But tell us some of this incredible data about CAR T-cell in general.
So I think the concept is quite elegant. It's been around for, well over 15 years, and it started in, pediatric ALL and B-cell malignancies. But, taking a patient's T-cell, teaching it how to identify cancer cells and going after them is a very elegant idea. And, we have 2 products, which are very effective, but they do require preparation. So, it's not that, patients can get those CAR T-cell therapies right away. So I think while they're highly effective, I think my general sense is the number of patients who eventually get to CAR T-cell therapy are going to be lower than what we'd like it to be. So the point being, there's room for all these different therapeutic strategies for our patients, and their use is going to be mutually exclusive. CAR T-cell therapies will require, a patient undergoing what we call lymphodepleting chemotherapy. So, kind of dialing down the patient's immune system and existing T cells and B cells, and then giving them this engineered T-cell therapy after having collected it from the patients ahead of time, and manufacturing takes about 4 odd weeks or so. Once patients get this T-cell therapy, we watch them for side effects. The 3 things we're looking for: low blood counts, which will happen as a function of having received some chemotherapy and the CAR T cells. As these T cells are super active, they kind of, the body mimics as if it's been infected, and these T cells are, pouring out, chemicals to galvanize the immune system to go after these cancer cells. So patients, may feel as if, that they're in a state of infection, and that's called cytokine release syndrome. So that requires early recognition and management, and that's why, many of these patients are watched in the inpatient setting. But that gets better very quickly. We have learned to recognize it early. It's very reversible, and for the most part, it's very, grade 1 or 2 CRS that patients get that we manage very effectively. And the neurotoxicity side effect also happens because of these T cells becoming active. Patients may have there may be several different things that can happen. Either feeling a bit loopy, having some nerve palsies. All of these things end up being reversible as you recognize these kind of changes early and manage them with steroids. So the first 2 or 3 months are fairly labor intensive, but then when the numbers counts start to improve, these symptoms have already been taken care of, patients really start enjoying their quality of life because they're not on any other therapy. And that's the idea that I really like about CAR T-cell therapy is, yes, you're putting in this effort on the front end, but then once you've recovered, you enjoy a high response rate. You're not on any therapy. You have a better quality of life. And that's what's the most appealing part of CAR T-cell therapy. I'm so sorry about the long answer, Joe, but I want to make sure that I cover everything.
No, you covered it brilliantly. And I mean, that one and done concept, it cannot be underestimated. I mean, I had a patient not long ago come and say to me, doc, I love you, but I'm glad I'm not seeing you that much, because he'd been off all therapy for 2.5 years. He felt the best he'd ever felt with myeloma. He had myeloma for almost 10 years now. He said, no chemo brain, I feel well. Before we wrap up, I mean, we do have to note that there is a challenge getting CAR T. Of course, as you mentioned, you have to be at a larger center that can do the pheresis and everything. But also we've had supply chain issues and lots of challenges accessing this. we really hope it's going to improve now that we have 2 products on the market. And I know we're all optimistic about it, but I think realistically, and as I'm sure you're experiencing even in New York, that there is still quite a waiting line for people to get this therapy. And so the last question I have for you is, if it's going to take a long time for this patient to get to CAR T, and so they end up getting belantamab, for example, are you comfortable taking someone from belantamab to CAR T if they're doing BCMA to BCMA?
I would be comfortable doing that. I don't see that as a major challenge. Interestingly, we now actually have some groups looking at this as a clinical trial question as well. Can you utilize a BCMA-directed strategy before you take patients to CAR T? So absolutely, yes.
Great. Well, thanks so much for joining me today, Saad. This has been a great discussion, as I expected. I so much appreciate your expertise, your skill, and your passion for patients. It's very clear, and it comes through when we have this conversation. So we've talked today about triple-class refractory myeloma. This is something becoming more common in myeloma as we use more of these classes early on. Patients are going to become triple-class refractory even in earlier stages. Right now, 3 major approaches: selinexor, which when we use weekly and in combination is more tolerable and more effective; belantamab mafodotin, that despite some of the keratopathy issues can be very effective, but we have to be very careful in managing the keratopathy; and CAR T-cell therapy, which may well be the most effective therapy we have in triple-class refractory myeloma. And it does come with short-term challenges and may indeed require a longer time before we can have it more accessible, but we trust it'll be more accessible soon. I really appreciate your time with me today, Saad. This has been very helpful, and I trust our audience have enjoyed it. So thank you for joining me.
Thanks for listening to Medscape's In Discussion Multiple Myeloma podcast series with our host, Dr. Joseph Mikhael. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com for show notes, links, and more information on multiple myeloma.